Thank you. Thank you to Charlie for engineering all of this as always. We have a change in voting members on the TAC. The representative for NAMI Kentucky, as you all know, has been Sarah Kidder for the last couple of years, but Sarah is no longer working in that position with NAMI Kentucky. And so NAMI Kentucky has nominated and appointed rather TJ Lidovic. And TJ, if you want to wave to people so we can say hello. There you are. Good to see you. We welcome you to the work of the Behavioral Health TAC. Glad to have you on board. And is our court reporter with us, Charlie?
Yes, she is.
Okay. All right, great. If folks want to, let's go around and just be sure each of the voting members of the TAC, so you can introduce yourself to TJ. So Val?
I'm Valerie Mudd, and with NAMI Lexington, the National Alliance of Mental Illness, and I represent the consumer voice.
Great. And Eddie Reynolds?
I'm Eddie Reynolds, Program Director with the Brain Injury Alliance of Kentucky, and we've worked with NAMI Kentucky quite a bit, so glad to have you on board.
Great. And Mike Berry?
Hi, everybody. Mike Berry, CEO of PAR, People Advocating Recovery. And I'm a person in long-term recovery from alcohol and drugs, 27 years now.
Good for you, Mike. Mike is our deep throat, our voice. And Diane Shermer? Oh, Diane may not be with us yet. And Steve Shannon, have you been able to join? Okay, and TJ, you want to give just a second of your background for us?
Yes, I'm pleased to be working with NAMI Kentucky now. I have a lobbying and consulting firm here in Lexington, and I started working with NAMI Kentucky last summer in a strategic advisor capacity. And then when Sarah had to relinquish the role as the advocacy coordinator / lobbyist, I came in to fill that vacuum. And I look forward to working with everybody to achieve our shared goals for mental health in Kentucky.
Great. We look forward to that. Charlie, you asked about Eddie. Eddie was added, didn't replace anybody. We, in the legislation of a year ago, we added the Brain Injury Alliance of Kentucky position, as well as the Diane Shermer position, which is the Brain Injury Association of America. So we increased our voting members from 6 to 7.
Okay, so I had Gail as being the Brain Injury Alliance of Kentucky. Is that
right? And so Eddie had replaced Gail, and I sent you his contact information and that letter from BIAK.
Okay, I have apparently overlooked it. Sorry about that.
Yeah, no problem. And you have TJ's contact information. I'll put my grid together for you, Charlie. I didn't have time today, but I'll send it to you and send it to the voting members so everybody has everybody's contact information. Okay.
That's fine. I did get TJ's this morning. I did see that one, but
yeah. So the other one was a replacement of Gail resigned from or retired, I guess, actually, Eddie, from the board of BIAC, and so they have appointed Eddie.
That's right. Gail retired last year.
Yeah. So I sent out the draft meeting minutes of our November 3rd meeting of the BH TAC, and I would entertain a motion from one of the voting members to approve the minutes.
So moved. This is Mike.
Okay.
Val,
And second from Val. Any additions, corrections, omissions, questions? Seeing none, all in favor of approving the minutes as distributed, signify by saying aye.
Aye.
And opposed, like sign, and abstentions. Okay. Just very recently, I got a response from the Department for Medicaid Services on our recommendation that we made to the MAC back in November. And that recommendation was to encourage Medicaid to gather data on behavioral health services which have been denied for third-party liability by commercial insurance carriers over the past 2 years in order to determine the top 10 services which are not covered by commercial carriers, but should be covered by Medicaid so that we could have a systems change to create a bypass to make these claims eligible for reimbursement by Medicaid. So that's a very complicated way of saying we're still having this problem with the, what we call the dual eligibles, people that have Medicaid plus some other coverage. And we've worked out a bypass or a workaround for those who have both Medicaid and Medicare, but we're still having problems with Medicaid in a commercial insurer, and that's typically our kids. So it affects those kids that are treated by the Children's Alliance members or the CMHCs and needing services. So I'm very pleased to say that we got a positive response for Medicaid that they will request the data for further research, evaluation, and discussion purposes. So we thank Medicaid. I'm not sure who is on from Medicaid, but I'm very pleased with that positive response. The next is the status of our data request from Medicaid on targeted case management. And this is been a huge issue. And we again really appreciate the support of Medicaid and really doing a deep dive into the Medicaid data to look at what the impact of targeted case management has been. So I think at maybe our September meeting last year, I reported that we had some preliminary data reported from Medicaid. And as you can imagine, it's a huge amount of data. So we're honing in on the definition of folks with severe mental illness, and then asking them to also look at all kinds of categories of expenditures, because one of the things that we really want to look at is whether targeted case management is helping alleviate or increasing access to services and maybe eliminating high-cost services like ER visits, additional hospitalizations, and so forth. So after that first meeting, we had a good conversation with them. We asked for a second run of the data to really hone in and do a kind of pre and post test where they would look at our folks that meet the criteria of having at least 6 months worth of targeted case management. And they would go back and look at the 6 months prior to TCM being instituted, and then look at 6 months after the individual had had targeted case management for 6 months. So we have that comparison pre and post. And we just got that data from them in late on Monday afternoon, and we are so grateful to Laxmi and Barbara Epperson over at Oates and the Medicaid, where the Medicaid data warehouse is. Come in. Come in. Sorry, my bug man is here. Hello. We have not had time to really do a good analysis of that data, but there's some preliminary stuff that Kathy Dobbins got to take a look at And Kathy, I don't know if you're on or not. Are you with us? Maybe not. So she had pointed out some kind of immediate things that jumped out in terms of some data that would indicate that people are getting more services when they have targeted case management, and that there may be some declines in some of those high cost things. So I'm going to target our March meeting for our little work group that's been working on this data to have finished at least a very complete preliminary analysis and make a report back to you all. But my thanks go out to the Department for Medicaid Services, to the commissioner in particular, who really got us started on this well over a year ago, talking about wanting to use data to make decisions, and so wanting to see what the impact of targeted case management has been on the lives of people that meet this severe mental illness definition. So that's a comebacker for our March meeting, but we're very excited to have this data and to have the opportunity to go through it. So Dr. Brenzel is in that group, Steve Shannon, Kathy Dobbins, Natalie Cunningham, and Mark Kelly and myself. So it's a range of people that have a lot of experience with this. And again, my thanks to Medicaid for that. So stay tuned on that. The next item is something that, again, we've talked about a whole lot, and that is the update on claims payments for services to dual eligibles. So I'm wondering, and I don't know if Steve is on yet. I know Kathy Adams couldn't be here today.
I'm on.
Oh, okay, Steve, great. Have you seen any differences with the bypass in place?
Yeah, it's getting better. There's still some concerns. Most of my time has been on CCBHC claims, but overall, we're seeing some progress made on that bypass list. We still struggle with folks, and this is really a children's issue as well, Medicaid and commercial insurance.
Right.
But we're hoping the Medicare and Medicaid one is close to being addressed. But we'll see.
Yeah.
It'll take a while to make sure it goes through the process, those claims are done correctly.
Yeah, and I don't know if you were on when I reported that DMS is going to look at that data that we requested in our recommendation back in November. And again, I can't see who's on from Medicaid. Does anybody have any idea about a time frame to look at that data?
Lee and Angie, and I think Deputy Commissioner Cecil.
This is Angie with Medicaid. I did look at it briefly.
Okay.
I did pull it up and kind of looked to see what the comparisons were before and after CCM. I can't say that it was a lot different.
No, I'm asking about Angie, about the time frame on this new request that we have for data.
I
Yeah.
am so sorry.
Yeah,
No.
no problem at all. We got the favorable response back on dated January 4th from DMS that they would look at that data on the claims on commercial, the denied claims under third-party liability for the commercial insurers, so that we could start working on a bypass in that system as well. And I was just curious about what our time frame ought to be to look for some report back on that data. And there may not be anybody on who's in a position to respond to that.
Hi, it's Veronica Cecil with Medicaid. And Lee, I was also looking to see who might be working on that project.
Yeah, I have nothing to offer on this topic at this moment. And I just wanted to say that to let you know that I am hearing you and I hear the question.
Okay.
I'll have to go back and take a look at some other information.
Yeah, I do think, Dr. Schuster, that the commissioner actually is pulling the data.
Oh, Okay,
So, but we'll
that's
look
impressive.
around. Yes, well, this and the targeted case management are, I think, are important issues to her, but we will go back and make sure that one of us are up to date on what's going on with it. So I know the request has been made. You know, generally it can be 30 to 60 days, depending on, you know, it is session, and when we're pulling data, sometimes requests get pushed down the line based on
Sure.
on priority. But yeah, we'll definitely report back to you on that.
Yeah, and maybe Veronica, you and I could communicate, you know, 6 weeks from now, so I know whether to put it back on the agenda for the March meeting or not. And that's really what I'm looking at. And certainly our commissioners is looking at it and so forth. That's great.
Yeah, I think that's a good plan.
Yeah. So we will definitely do that. And again, we really do appreciate that positive response and having the data. So thank you very much. Well, we're just zipping through this agenda today. So the next is, I think, a report from the MCOs on how the no-show data is being used by the MCOs. You know, we've had this, TJ, you're new to this. The department has put up a data gathering reporting system for providers to report when people miss their appointments. And we've expressed some concerns about how that data would be used, wanting to be sure that people aren't, and this would be obviously an unintended consequence, but if people are not being stigmatized or seen negatively because they're having problems getting to appointments. And so we understand that that data has been shared with the MCOs. So they're being told who in their client caseload are having trouble keeping their appointments and are doing some outreach. So that's what we're interested in hearing from. And I think, Veronica, you sent that request out to the MCOs after you and I had some back and forth about it, right?
Yep, that's correct. So each MCO should be prepared to discuss it. So I don't know if you want to go in any certain order.
Well, we can always go alphabetically, or we could start in the middle. We'll go alphabetically this time. So I don't know who's on from Aetna.
Hi, this is Kat Jones with Aetna.
Hi, Kat.
Hello. So we do receive these reports, and we are in the process of figuring out a process for case management outreach, but it has been a challenge to get oriented and work through that process because the report includes very limited information. We have the member Medicaid IDs, but we don't have any information about the provider, and so it's a lengthy list, and it's hard to determine how to prioritize maybe those members that need outreach maybe sooner than the others on the list. For example, if we had the provider information, we might be able to tell, oh, this is a behavioral health, and be able to look at that member and see, oh, they missed their appointment after their hospitalization, and can prioritize, our case management work. So we're trying to figure out how to make that report useful and how we can best, maybe is there other information we can pull from our systems utilizing those member IDs to make that list as useful as far as outreach as possible. So that's where we are at this time.
Okay, and I don't remember that screenshot well enough. So Lee, let me turn to you because I know that you're the one that's reported on this or given us the information
I am, and Dr. Schuster, I'm looking for we just got those reports. What I believe is that perhaps Kat hasn't seen all of them. There are two different sets of reports that go to the MCOs.
Okay.
And I believe one of them has the provider on it. But if you would go ahead and let me find them in my emails, I can speak more definitively on those.
Okay. All right.
This is Stuart on of WellCare. Sorry to cut in. So on that topic, we emailed DMS a couple weeks ago and said that, we really need the provider name and we need the date of service. And DMS responded back quickly that beginning with the February report, they will list the provider name and date of service on the report. So we should be getting that. All the MCOs should be getting that beginning in February. But Kat is exactly right. All
Great.
it has right now is member ID, and that's it. So sorry to jump ahead.
Oh, well, that's helpful to know. So that these initial reports that went out gave you a long list of your members
Right.
with the information that they had missed appointments. But that was
Not
it.
when, right. Didn't say when, didn't say who the provider was. So, if you call, you say, we understand you missed an appointment. Who? We don't know. When? I don't know. So, but anyway, beginning in February, we understand that's going to be included on the report.
Okay. Did it give us, Stuart, did it give the number of missed appointments for each
Yes.
person? Okay.
Yeah. So we have the DMS sends us a monthly report, and then they send us a cumulative one, maybe a couple of weeks ago or so for, I think this began in July. And so that one shows for that period, the frequency, how many times each member missed.
Okay. But I think the example that Kat gave is that if you've got somebody who has missed behavioral health appointments and has a primary mental health diagnosis, that would kind of red flag that. Maybe that's a bad term because there are other red flags mean other things in legislation and so forth. But anyway, that would flag for you that might be a higher priority.
Exactly. And along those lines, I don't know if you want me to wait for the W, I'm at the end, or go ahead.
Well, we'll go back and forth. Go ahead. Thank you.
Okay. So we were curious about how many have a behavioral health diagnosis. And so, because we have the member ID, we can pull that, we can, run the claims. And we found out, and I guess this was this would have been probably for the whole calendar year, but 22% of those that missed appointments had a severe mental illness. And compared to the quote, average population, 9% have an SMI, the Medicaid population.
Right.
12% have a serious emotional disability compared to 6% average. So that's more than double. We were curious about ER visits. 93% of those that missed appointments during that time period had an ER visit within the past year, which is about twice. And also 5% had a behavioral health admission. So that's, that's over 3 times the average, maybe 3.25 times the average for the general population. So obviously there's a high prevalence of behavioral health diagnosis among those that are missing appointments.
Right. That's
And
fascinating.
this is Dr. Cook from United Healthcare, and I thank you for sharing that, Stuart. I think the other thing that we're looking for with that report is, as we're looking at where the members are missing appointments at, like the providers, not necessarily in a punitive way, but looking at how can we then reach out to the providers and support them in this process as well when we see the missed appointments from the members. So that extra detail that I understand, I was on a call earlier today, that will come in the February report will really be helpful for us to see trends as well, and how we can then work with the providers and the members to try to build around getting those appointments made for the members. So I just wanted to add that as well.
Yeah. Steve, could you take over and chair the meeting for a minute? I've got to take an emergency call here.
Sure.
Thank you.
What about Anthem?
Hey, Steve.
Hey.
Sure. This is David Crowley, Director of Behavioral Health for Anthem. So Anthem uses this report and merges it onto one of our internal clinical risk indicator reports. That way we flag the most medically fragile members from our internal data that, includes all claims and utilization trends. Once we have those members flagged that are in the highest groups 3 and 4, those are then queued for our, highest level of intensive case management outreach. And then for the members that don't fall into the highest clinical risk indicators, we then kind of filter it down to those members that have missed 3 or more appointments. And although they might be lower risk overall, we engage those members with our community engagement navigators because more than likely it could be an aspect of social determinants of health that we could try and troubleshoot within our community resources. But it will be really, I think, really significant in that February report, like others have noted, whenever we start receiving which provider that made the report of a missed appointment. That way we can work kind of more collaboratively with those members and providers that have a missed appointment.
Okay. Any questions for Anthem? Thanks, David. What about Humana?
Hi, good afternoon. It's Liz Stearman. Hi, good afternoon. It's Liz Stearman. Sorry, I was double muted there from Humana, Healthy Horizons in Kentucky. As far as how we are utilizing this report, every single one of our members that is populated on the report will be receiving a letter in the mail detailing the importance of attending appointments, notifying providers if they miss appointments, as well as including the case management phone number and email address to assist in finding a provider, if they need help rescheduling or removing barriers, so that if they're receiving that letter, they'll have that easy, quick way to connect with our team. Additionally, if we have identified a member on that report that's already engaged in care management, the care manager will do a one-to-one outreach to help them identify if there are any barriers that need removal, if they need to find a new provider, reschedule. Additionally, we have been filtering for some of those SDOH barriers that I know Anthem was just mentioning as well. So if we see there is actually like a reason that the providers are able to notate on that report on why the appointment was missed, if they know it. And so if it's indicated on the report that either child care or transportation were the barriers that caused them to miss the report or miss the appointment, a member of our population health team, so a community health worker, SDOH coordinator, care coach, someone will reach out to them specifically around that issue to try and assist with any kind of resources. And then lastly, if an enrollee appears to have a recurring issue with more than 3 missed appointments, they will also get individual outreach. All of those things are put in place because, as everybody else has said, we're working with a little bit of an information vacuum. And when we have those provider IDs, our intention is to be able to also apply a, sort of a provider specialty filter to that, to be able to triage for those, like you guys have said, that have either a behavioral health appointment or another critical appointment. We're looking at our high-risk OB members. If they are missing their OB appointments, obviously those will go up to the top of the list and doing some triage there as well. I know Dr. Schuster has mentioned several times that the concern was being able to use it in a punitive way. I think, we're all taking that approach, that this is an opportunity for us to get our members that need access to care a much closer tie to those providers.
And you're going to send a letter. A lot of the folks that we serve at CMHCs, I mean, the mail isn't necessarily always the best approach. Is there a secondary strategy? I mean, a lot of our folks don't get mail or don't look at their mail or are reluctant to open mail, especially from an insurer, maybe.
Yeah, we are doing that as our baseline. I mean, that's when we get the information and all we have is that provider ID. Again, I think someone else talked about the volume of people on the list. We don't want to have to do a phone call to every single person. It's similar to not opening mail. A lot of folks are either don't have a good phone number or not going to answer the call from the insurance company. So That's just sort of that's the bottom tier approach, and that's why those additional calls and identifying the members who already have an established relationship with a care manager are going to get that additional outreach.
Great. All right.
This is Kat at again. So building off of that, we're looking at text messaging campaigns as soon as we can get. The more detailed information, the more targeted that we can be. And you know, a lot of times that communication by text is more effective than letter or even phone call. So that's another option that we're exploring and trying to build into this using this report.
All right, great. Anybody else? All right, passport.
Nope, no, I'm sorry. I thought you were finished with the MCOs. Go ahead. Go ahead.
Passport.
Well, good afternoon. This is Liz McCune. I'm the AVP of Population and Behavioral Health Strategy at Passport by Molina. And the strategies that we have in place sound fairly similar to what others have at this point. The first thing we do when the list comes in is we attach the assigned PCP because we have that in our data file. So we since we didn't have the providers on there, we're attempting to try to figure out who is this person at least engaging in some care with. And then we are going through and looking for those members that are already engaged in case management. We are having a task put into our record file so that the next time that the case manager goes in, they'll see for their particular member that an outreach needs to be done to find out what happened and why they might not have shown up for an appointment. If the members aren't in case management, we're stratifying that data. And if they missed for an SDOH reason for a social determinants of health reason, if that's documented, we're having our community connectors reach out to try to figure out what happened and again, connect them to resources in the community to help them hopefully get to an appointment. And if they missed more than 3 appointments, we are also assigning them to a community connector. And those would be people that we might not know why they had missed if it didn't have that it was an SDOH need, so that we are doing some outreach. We also have a group that has been meeting that is working on drafting a communication where we were going to send out a letter to all members that were appearing on the list so that there was at least some sort of outreach and contact to every person because the list is rather long. But we're looking forward to having more information about the missed visit, including the provider on that February file.
Thanks, Liz. Any questions for Passport by Molina? All right. Any questions about this issue at all?
Just on a personal note, with my own provider, what my provider says is that after 3 missed visits, they call for a welfare check. So that's what happens with me personally.
Okay. All right. Have you had it? I mean, you haven't missed 3, have you, Val? To see what that's like.
No,
So.
I've been good.
I just want to know what happens on a welfare check. You know?
No.
I'm not questioning you.
The police come and knock on the door.
That's what I was afraid of.
Yes, you think it's a scary thing.
It's punitive. I hope that's not what it is.
Well, sometimes it's the fire department that does it every once in a while.
Yeah.
Yeah, this is Lee Geis again. I apologize. I didn't announce who I was. But I knew there were 2 reports that went to the MCOs. I'm thankful that Stuart was on the phone and on the call and in the meeting and has already made the request to have that report updated. Right. The second report is the reason that that the patients/members given for missing their appointments. And so That's where I was confused because I knew there were two separate ones, one with the member's name, identifying information, not the name, but their Medicaid number. So just wanted to clear that up, and I'm glad we were able to modify the report for February so it's more useful. Thanks.
And I was serious. I would hate to think the police show up. And I know a welfare check, but I hope there's a different strategy for insurers, because that's gonna, I think, chase a lot of people away from services, not to services, which isn't the objective of this data, right? So.
I think in the case of what Val was saying is if her doctor she doesn't see her doctor and misses 3 that they call a well check. I'm pretty sure those are either police or firefighters that come out. And I mean, you don't know when they're coming or why they're coming, but they basically just knock on your door and
Right.
not that I've had one, but I do know somebody that has one. They just came to their door and just said that someone had called them and was concerned about their welfare and just wanted them to check.
All right. Okay. Still concerned. A lot of folks who are really mentally ill are not going to respond well to that, if that's the approach. Right, Val? I suspect you hear that at participation station.
Yeah, absolutely, absolutely.
I bet Kelly Gunny has heard the same story.
It's really hard for people that suffer from paranoia. And, that's most likely, I'm sorry to generalize, but oftentimes those are the individuals that miss appointments due to symptom load. So that would be a pretty scary thing to do.
Yeah. All right. Dr. Schuster's back. We've gotten the updates on the data, on the missed appointment stuff. The last conversation was Valerie Mudd shared with us, Sheila, that if she misses 3, there's a welfare check. And
Right.
we've expressed concerns about, for some folks, police or fire showing up for missed appointments. But
Yeah. Does it make sense to keep this on the agenda for March? Because you all will have the new data sets.
yeah, I
You're
think
going
so.
to get them in February. So let's revisit this in March. So you all will have a more finer tuned. I love the data that I don't love the content of it, but I love the idea, Stuart, of what WellCare has done in terms of analyzing that data and comparing it to, a kind of more typical population to see what we're finding, because that's, some other pieces that we could look at there. So I appreciate you all, and we'll bring that back. I also appreciate Medicaid refining that data reporting so that you have the information that you need to make this really useful. Val, you're in a position, and some of our CMHCs may be in a position to hear from people if they have had a missed appointment, and then when you next see them on the provider side, to see if they did get some reach out and how that was perceived. But Val, you're in a position, I think, with your consumers at participation station to kind of get, hear what the scuttlebutt is on that from their perspective. That would be really helpful. Kelly?
Sheila, what we hear a lot of times, and I'm sure Valerie can validate this, is there does seem to be a punitive type of response too often, where if you miss your appointment, well, it's going to be 6 to 8 weeks before we can get you another appointment, sometimes even longer. And that just seems ridiculous, because sometimes, there's no way to get there. There's no transportation. It is those social determinants of health that keep them from making the appointment to begin with, or it's symptom load. So more often than not, and Valerie, this was the case before the new year. I'm sure not much has changed, if anything. And with COVID raging, it seems to be even more prominent. but everybody's dealing with, staff shortages and those things too. But I hope there's a better way that we can do it besides really putting off appointments for people that have already missed appointments. That's a recipe for disaster.
Well, I guess the other piece of this, Lee, when you all get that data, and again, I can't remember, but the providers that are putting that data in, do they indicate whether that was an in-person visit or a telehealth visit?
Dr. Schuster, I think Lee had to drop off another meeting, but I'm pretty certain it does not capture that.
Well, it seems to me that would be a really important thing to capture. Certainly we have so many more telehealth. And I guess we're assuming that people are not missing their telehealth appointments, but I wonder if that's the case.
They are missing them, Sheila. At least I can only speak for our group that we're in regular interaction with. And Valerie, would you say that's the case?
Yes, I would. Because, well, besides the fact that people don't like the whole Zoom environment to begin with, with the paranoia issues and all that kind of stuff. I mean, that adds to, missing their appointments as well.
Well, I mean, I think we would be concerned if they're missing the appointment, regardless if it's telehealth or in person. So I think capturing the fact they missed it is prompts, as we've heard from the MCOs, which was the expectation, prompts some additional follow-up. And then at that time they can determine, is it transportation? If they have an opportunity to actually outreach to the member and or the provider to see if that's, is it a technology issue? Is it transportation? It's still, we're still digging into non-emergency transportation and why folks don't access it, and what can we do to make it more accessible. That's another area the commissioner is very interested in is we've got this benefit, and why aren't members taking more advantage of it, and are there barriers that are standing in the way of its use? So and again, the take back from all this is what we hope is that further conversations through the MCOs about what are they finding and what can we do to make changes to help to reduce any barriers.
Yeah. Yeah, the non-emergency medical transportation has been a bugaboo for years and years.
Long time.
And it works in some places and not in others, that it works with some transporters and not with others. But I wonder if our behavioral health folks or folks with the behavioral health diagnosis have more reluctance or more difficulty doing non-emergency transportation. You think so, Kelly?
Our folks, and I think again, Valerie could vouch for this, it's very difficult because, you have to call so far ahead of time, and then there's no guarantee you're going to get to your appointment on time. The public transportation in Lexington and Fayette County in particular is very daunting to navigate. We actually have, people that's their job, is to teach people how to use the bus. And, it's not easy. And the timing is terrible for a lot of these things and routes. And what if your appointment isn't in the schedule of the bus and the wheels people didn't show up on time? And, there's just all kinds of issues that we face with that.
Yeah.
This is
Wheels, you have to give 24-hour notice, before you can get somewhere. And, sometimes that's hard to do, and again, they may have to stop and pick somebody else up on the way, so they may be late for their appointment or whatever, so it's a difficult situation. So
somebody was wanting to add something.
Yeah, this is me, Stuart, again with WellCare. That was definitely something we were curious about with telehealth, the expansion of telehealth because of COVID. Even before COVID, we were wondering, especially if transportation's an issue, we, figured probably a lot of providers are offering services through telehealth now. We were curious about that because that would, eliminate that barrier. So I was just kind of curious. I mean, among you all, are you aware of telehealth being pretty commonly offered? I guess, this is just the behavioral health TAC, but is that, would you say, I don't know if you have any kind of estimate, 50% are offering it or any kind of idea?
Steve, you have an idea? I would guess it's upwards of 50%.
Yeah, I mean, I know that all the CMHCs are.
Okay.
They've made it available. Even to the extent some actually have an office in person. The person shows up, they go to an office and there's a person in the building seeing them, and then everything, make sure there's no exposure, 6 feet apart, all that stuff. So, and that really, if there's an upside to COVID, which seems unlikely, it's telehealth. I mean, it's really changed the dynamic, and it forced the CMHCs for sure and other providers to ramp up and provide those services, and the allowances that the cabinet has made in the utilization of telehealth has been a game changer as well. So we're very active in it. We're doing it. We're trying to figure out what the future looks like, the extent of telehealth, and how much we're doing, and who works well, who doesn't work well. I know
Right.
Dr. Sheila at one time, Dr. Schuster contacted folks. Adolescent males really like it.
Yeah.
They're familiar with the technology, they're comfortable with it.
Right.
Go on from there. So I think it's something we're going to keep doing and refine and become better at. And really, the challenge now is to match who's really good at providing the services and what groups of folks are good at receiving it. And it works well, and go on to that place and become more strategic in our utilization. But right now, it's the first choice for a lot of people.
Yeah, probably, Stuart. I did a survey, an informal survey, calling people, called the CMHCs, called folks like the NAMI outfits like Kelly, Val, and so forth, to get some feedback on telehealth. And one of the things that so many of the providers reported was, a sharp decline in missed appointments, and sharp decline in no-shows and so forth, which, was very encouraging. Now, that was from the provider standpoint. Again, I think there are some people for whom it doesn't work. I think there's some people that are older, less familiar with and less comfortable with the computer and so forth, that probably are not. I think children on the autism or teenagers on the autism spectrum have a hard time. Kids with ADHD, you have a hard time keeping them engaged. And I think the security issues came up a lot. You have an adolescent or you have a kid and they're in their living room with family members coming and going and so forth. And we heard from kids that they were locking themselves in the bathroom so that they could have some privacy while they were having a session. So there's some downsides to it too, obviously, but yeah. All right.
If you're anything like me, I mean, I'm on Medicare and I do telehealth. I've been doing telehealth with my med manager, and it's totally free. I'm like, well, heck, I'm not going to get in my car, get dressed, and spend an hour to get there, whatever, it's totally free. Hey, there you go.
Yeah. Well, ongoing conversation. It looks like we're going to be in the world of telehealth for quite a while here, if you look at the COVID numbers and so forth.
Kelly has a question, Sheila, or a comment?
Sorry, Kelly. Yeah.
Sheila, I just want to say maybe a more targeted approach would be to look at the people that aren't engaging in telehealth. The ones that are, that's great, but it's these cohorts that you just mentioned that aren't prone to engaging in telehealth. So what are the options there? Because I think that's going to be smaller cohorts of people, like you said, elderly people, and just the populations you just mentioned. So it's coming up with a strategy for outreach to those groups.
Yeah, I think absolutely. And I think there continue to be providers that really are struggling with doing their work via telehealth, depending on the kind of therapy that they're offering and so forth. So it goes, I think, both ways.
Well, in rural areas, there's the issue of bandwidth for even having, the ability to connect. So those are huge issues in those areas as well.
Yeah. And I think once you get real disjointed communication, that makes it a therapy session almost impossible. Real hard to establish rapport and so forth with that going on. I would think that the MCOs, when they follow up with people, are going to be asking those questions in terms of whether this was a telehealth visit or physical health visit. Val?
I'll be honest, when I first started doing telehealth, I mean, I had the paranoia feelings about, okay, where is my therapist, or where is this person sitting? You know, can other people hear my conversation through, you know, all that kind of stuff. And I can probably name, I don't know, 5 people right off the bat that I know do not do telehealth because they don't like the camera. And, you know,
Right.
and the paranoia is seriously there. So,
Yeah. Good feedback, good discussion. Thank you. I keep putting on the issue of EMS transportation of individuals with behavioral health issues. I will tell you that the Hospital Association has been working with me, with the Mental Health Coalition, with the nursing homes, with hospice, to come together behind a bill. And I think we're going to see that filed maybe this coming week by Representative Ken Fleming, who's a Republican from Jefferson County. And it's going to look at creating a kind of a work group, actually, to talk about these transportation problems. This stems back to years. You know, this came up 4 years ago, in the BH TAC recommendations. We were hearing it at first, we thought it was just a rural issue, and now we realize that it's certainly an urban issue. And it started with ambulance drivers saying, well, we don't have to transport crazy people, or we don't have to transport people that have a behavioral health issue. And it actually is widespread now. We're finding it hospital to hospital. We're finding it from hospital to step-down services. We've heard stories from hospice about patients who were supposed to be picked up at the hospital and taken to a palliative care center or taken home so they could have hospice services available to them before they died. And there have been some horrible stories of people that actually died during this 24-hour waiting period while they were waiting to be transported, that were that close to the end of life and never got home to have hospice services. So, you know, it's really gotten way out of hand. So there's all kinds of issues around the way that the ambulance providers are licensed and so forth. So I will keep you updated about that legislation. And Steve, you want to talk a little bit about the 202A transportation issues?
Yeah, and this really came up. It started, I guess, October, November, and Representative Heverin and Representative Bray raised the issue that they've had some concerns, heard concerns about transportation 202A to hospitals, wait times for people primarily, stories where folks are actually waiting in the ER for 12, 14, 16 hours to be transported to one of the 4 state psychiatric hospitals, whether it's Western State, Central State, Eastern State, or Appalachian Regional Hospital. And you know, they met with several groups. They brought people in. I have not seen a bill. I haven't heard back. They wanted feedback from a variety of groups on December 15th, and I think the Hospital Association submitted stuff. Sheriff submitted stuff. I submitted information on behalf of CART member CMHCs. I know the advocates submitted information as well. And they're trying to figure out what's the best approach to make sure people aren't waiting to go. You know, Representative Bray clearly stated at one meeting, he doesn't understand why someone's waiting 16 hours for a 72-hour hold. Why is that taking place? Representative Heverin just wants a solution to this problem. She wants people to get to the hospital as quickly as they can. And their approach was going to be legislative. I haven't seen a draft yet. I'm sure we'll get that out to people when it's available. But, you know, what's the best way to get people to state psychiatric hospitals? You know, it's the sheriffs that do that. The sheriffs will tell you they have no training, they have no expertise. I think part of as kind of peeled it back, it's a judicial action and sheriffs transport people for judges. I think that's how we ended up there. And I think it's, we stated that we understand why. We don't think it's, as we all have said many times, mental health is part of health. And ambulance transports to hospitals. Why would this be any different? So that was our first statement to go forward. And I think a lot of folks expressed that same sentiment as well. But I don't think there's a great answer before us right yet, but hopefully we'll move towards getting prompt care for people who need it. I mean, that's a priority, and transportation that's not stigmatizing.
Yeah, that's
Putting it
what
back to the cruisers, not, I don't think is of therapeutic value.
Well, and you all remember when we were working so hard on Tim's Law, Faye Morton telling her story about 30 plus times seeing her son, who was never a danger to anyone but himself, being taken off in handcuffs in the back of the sheriff's car, 34, 37 times, just awful. So we did make a strong statement, and I know Steve, your group did as well. So we'll see about that. The original draft legislation that they shared with us, we think would be detrimental to the system. It simply said that they could just go to any hospital and drop them off. Didn't even say it had to be a hospital with a psych unit. Didn't say that it had to be a hospital that was trained to take people who were there involuntarily, which we know is a very different kettle of fish than people who are walking in and asking for treatment for their mental illness. So,
and I think they heard that message.
Yeah, I think they did too. So we'll see. I think they're finding out how really complex this is. Kelly? You're muted.
Yes, I know. I'm sorry. I just wanted to share with you that I've been researching some communities that are doing really good things. And unfortunately, last evening, my husband and I had the experience of having to be on the phone while our adolescent grandson was committed to involuntarily to a hospital in North Carolina. And when they got the magistrate to sign the order, immediately a crisis intervention team was notified, and they were given the choice for the crisis intervention team to come with an ambulance or to send police officers with a cruiser. And of course, they chose the ambulance. And so there was a crisis team officer, a CIT trained officer, with a paramedic and a social worker that came in the EMS vehicle to their home instead of a police cruiser, which would have ignited the neighbors. So there are communities that have mobile outreach teams that are doing this very well.
And that was for a youth.
Yes, this is for an adolescent, 16 years old.
Yeah.
Let me add, Medicaid just got the mobile crisis planning grant. And these are some of the issues that we definitely are going to be considering and hopefully developing solutions for as part of that planning grant.
We had heard, I guess, from a briefing that Steve and I had with Leslie Hoffman and some other folks, Veronica, about that grant coming in. Is there opportunity for public input on that, or at least a select group of people? I mean, obviously you're hearing a lot now, but this is just the tip of the iceberg in terms of, the people that are on the ground experiencing these things being able to give their feedback. So I hope that will be the case.
Yes, there will be a lot of stakeholder engagement as part of that, because the solution is in the community, and we need to know what's going on in the communities, and and we want to look at this more broadly across. This is law enforcement. We're going to need to get a very comprehensive approach and all the different sectors that touch this. And in order to develop a really good program for Kentucky. And we are looking at, other states and what they've done in other communities and what's going on with them. Because we're trying to learn those lessons too.
Great. Maybe Kelly can send you her research, particularly with her family's recent brush up against the system, but I'm really glad to hear that. I do think that the mobile crisis units, mobile response, crisis response is so much a part of what needs to be happening, whether it's Tim's law, or it's a 202A, or if legislation goes forward on the crisis aversion rights retention, which is to remove a gun in the midst of a crisis if a person is in danger of hurting themselves through a suicide or hurting somebody else. I mean, there's so many places where we really need to have that up and running and very functional. So that's exciting. Thank you for sharing that.
Can I interrupt just 1 second?
Sure.
Leanne just sent me a note that she has to drop off early for a 3:30 meeting, and she is giving the update on the SUD services for situated persons and so forth. Could she go next on your agenda?
Yes, absolutely. Thank you, Charlie. And
Thank
thanks,
you, Charlie.
Yeah, thanks, Leanne, for being on. I didn't see Leslie on, so.
Leslie's not feeling well, so I'm a
Oh.
replacement. And one thing on the mobile crisis planning grant, I am working on that. And tomorrow we should be sending out our survey to our state stakeholder members. And then we are working on our community state stakeholders. I'm going to put my email in the chat. And if you would like to be a part of the community stakeholders, just send me an email and I'll be glad to add you on that. We're looking for a couple weeks out on that because we just finished the state information, and we'll get on our community providers, lived experience as well.
Wonderful. Thank you.
Mm-hmm. And on our 1115 SUD incarceration amendment, things are moving along. CMS has asked several questions about our budget neutrality, and we're working on that. That's kind of it's a heavy lift, but with them asking questions, it's looking positive. We did meet with CMS earlier this week, and they're still not sure of policies and procedures around what we're asking for. We're asking for Medicaid to pay for services behind the wall. Currently, our DOC program, Department of Corrections, they offer SAP and SOAR SUD treatment to those inmates, which, of course, federal states that we cannot offer any services and pay for benefits for someone who is incarcerated. So we're asking for that rule to be taken away. And then we're also asking for an average of 30 days post-release that we can get that inmate to their MCO of their choice and work on, setting up appointments, whatever needs they might have. There have been several states that have turned in 1115 for that portion, for the 30 days prior to release, to get hooked up with the MCO and have the benefits turned on so that they can go and do their assessments and what they need to help them get back into the community after they are released. That MCO worker would work with that individual for 12 months post-release as well. So questions are being asked. It is moving a little slowly, but we're getting a little bit of progress, a little bit here and there. Anybody have any questions?
I was pleased to hear from Leslie on another call I was on with her that you all had actually heard back from CMS and they had some questions, because we have had this on our agenda, to ask about for, I don't know, a year, however long it's been. And
Correct.
It feels like, every 2 months you all are saying, no, they're still encouraging, but no movement. So it's got to be movement, got to feel good that they're at least coming back and asking about. And I'm sure that the budget neutrality is a tough piece. That's a tough barrier to get over.
Right. Yes, it is. We're working on it.
Yeah. Okay. Any questions for Leanne? All right.
We appreciate movement, Leanne. Thank you for that.
You're very welcome. Thank you.
Yeah. Sorry that Leslie's not feeling good, and sorry that she couldn't report that good news to us. I'm sorry. Did somebody else have a question or comment?
No, this was Charlotte. I just said thanks for letting her go ahead.
Sure.
Thank you. Yes.
Yeah. And I see that Leanne has put her email in the chat. So please email her if you would like to be a part of the community stakeholder group that would be involved in the mobile crisis grant.
We also have an email box set up too, so I
okay.
give you both of those.
All right.
Thank you.
All right. Thank you so much. And tell Leslie that we are hopeful that it's not COVID and that she feels better. Thanks. All right. I think that we are at number 8, which is our update on any changes in Medicaid, single Medicaid formulary. And I don't know if we have anybody on from that part of Medicaid. Maybe not.
Sheila, this is Fatima. I'm on.
Oh, hi. Hi, Fatima. Thank you very much for being on. Do you have any update to report to us? Anything new and different or going on? Any problems? Any good things?
Yeah, so I do have one change to report, and that is the Antidepressants Class. So, you know, with September P&T changes, we went ahead and moved brand Wellbutrin, Pristiq, and Effexor, and Zoloft oral concentrate to preferred. And the generics were moved to non-preferred. And then after further consideration, we decided to move it back. So that's hot off the press. We made that change yesterday. So that change has gone into effect on the MCO end, and Magellan is working to, you know, move those generics back over to preferred. So by the end of this week, you know, we should see those changes across the board.
Okay, so let me be sure I understand this. So the original change was to put the name brand drugs on the preferred drug list and move the generics to non-preferred. And then as of yesterday, it's back to the old way.
That's
correct. Where the generics are the preferred.
Yes, that's
and
correct.
That's only for the antidepressant class?
Yeah, so we made those brand generic switches back after September P&T. So we made those switches, and then after further consideration, we've switched it back.
So, you know, we've had these questions before about the shift that we found in going to the single formulary, that there was this shift from generic to name brand as the preferred drug, which I never did quite understand. But at least in this one class, you've now taken it back to the way it used to be. I guess the question is, do you anticipate doing that for any of the other classes of psychiatric medications?
At this time, no. So it'll apply to those antidepressants.
Okay. And what was the rationale for making the change back, if I may ask? And if that's proprietary or something, I understand, but I'm just curious. Because I never understood the change the other way, I guess.
So the change to, you know, preferring brands is really around cost savings and the rebates that offset the upfront costs of those medications. So, you know, that's the general gist of why we prefer brand name medications. You know, we were hearing a lot of feedback from pharmacies about preferring the brand over the generic, especially since the generic has been out for some time for these products. It was a little difficult for pharmacies to access through their wholesalers. But, you know, this was a unique situation. We do make brand generic switches. I wouldn't say often, but we do make them. So, you know, a culmination of all that really got us to where we are today.
Okay. All right. And thank you. Does anybody have any issues around the Medicaid formulary? This is an opportunity to ask Dr. Ali about any of those. Anybody? No. Have you heard anything, Steve, from any of your medical directors or?
I have not.
Okay. All right. Well, hearing none, we will move on to the next, but we do appreciate your being on, Dr. Ali. That's always helpful to have you available. Obviously, access to the right medication and the right dosage at the right time for our people has always been our number one goal. So anything that we can do to make sure that there are not barriers to having that happen is really what we want to see happen. So thank you.
Sure, thank you.
Veronica, I think that we had this question at the last meeting about an increasing number and requirements for the MCO audits. Do you remember that discussion?
Angie, are you up to speed on that? I mean, what I can tell you is that obviously we don't have prior authorizations on behavioral health services. And when the pandemic started, certainly Medicaid indicated in working with MCOs that, we wanted to put a hold on audits, except for fraud, where there was clear indication of potential fraud. But I will tell you that CMS throughout the, from actually the beginning of the pandemic and throughout the last year and a half or so, continually asked the state when we were going to reinitiate them, because some states never stopped. And, some of CMS's contractors never stopped. So, so the state was, we were definitely put in a little bit of a, given a little pressure to make sure that we are appropriately auditing. We've tried to be very clear with the MCOs that if, they shouldn't just be auditing for auditing's sake. They should definitely be just doing algorithms, and where there's been identified something of concern, that they should be issuing audits for that. But they should definitely work with providers in response times. We understand that, still with the mail being delayed at times, missed letters or delayed letters, or additional time is needed because, again, you guys are on the front line helping us fight COVID. That if additional time is needed to provide the records or information, that those requests should be granted, and MCO should work with providers around that. So, we are trying to monitor it. We certainly understand that the last thing we want to do is overwhelm our providers with audits. But the other side to that is they are necessary. We are required to ensure that services are medically necessary. That's a requirement of CMS. But we still think that this is a time where providers and MCOs, and certainly with DMS oversight, is that it's being done appropriately. And Angie, I don't know if you have anything else to offer.
Thank you, Senior Deputy Commissioner. Not really. You hit on everything. Yeah, I believe some of the complaints that I had heard that the MCOs were only given 10 days, and my response was ask for more, and they should be able to give you more. 10 days is a very quick turnaround time, and depending on how many they may be asking for. So they should be giving you an ample amount of time. So if there's any concerns that you feel like they're not listening to you, by all means, you feel free to contact me.
I appreciate that, Angie, because and I think that was the message that we heard when we talked about this back in November. I think one of the issues that came up was an MCO asking for, a large number of cases, or, extending the number of audits at one time. So it was not only the short time frame, but it was really an inordinate number of cases. And is there some appeal to, for that, or some response that a provider, can do with that?
Well, some of it is based on how you're contracted with the provider and what your language does say about audits. So I would recommend that you look at that. But if they, if I don't, depending on your office, 5 could be too many at one time. My assumption would be that there should be some common theme to the audits, as the senior deputy commissioner had mentioned, that it's not just auditing for auditing's sake.
Right.
And so you can always push back from with the MCOs, and you should, if you have challenges with meeting any timeframes that they have set up, because as we need to make sure that patients are taken care of.
I will add, I don't mind sharing that Kentucky Medicaid just had a program integrity audit. And we certainly heard from the representatives from CMS is that they would like to see more auditing. They were a little concerned that there's not, what we try to avoid is arbitrary numbers. So, just go out and audit this many providers. I think there have to be spot checks, and some of that has to happen just for due diligence sake. But I think what we tried to explain to them is that we work very closely with our MCOs and our providers, and we tend to be selective and ensure that we're just truly identifying those cases where there is a concern, for fraud, waste, and abuse. So we try not to just do them arbitrarily.
Okay, well, I think that's helpful. I mean, I hear you all saying audits are a cost of doing business in some ways, and the cost of doing business with CMS and with DMS. I think one of the concerns, because I think the correlation that we heard from providers was that when no more prior auths were being allowed on behavioral health services, the number and scope of the audits went up very much at that time. And I don't know whether that really makes sense. It felt punitive, let's say, to some of the providers. Steve, you want to?
Yeah, that's what we heard. And it was a large volume. I mean, it was a lot of records in a short turnaround. And I think, Deputy Commissioner Parker, we've given the message back, push back, let's figure out how to get this. But it was, at times, it was a lot of records and paper records, so it was administratively onerous. We're all kind of remote. And a lot of the staff who would have gathered information was working from home. So people were coming in and having to do that. So I think that's what we were hearing. Truthfully, we've had 2 meetings with CEOs, December and January, and Sheila participates. These things hadn't come up. So maybe we made some progress in that piece, but we haven't heard about that. But there's still frustration over just the volume of it, and kind of get a letter and ask for this huge amount of records in a short term. No indication prior this is coming or anything, or what we do. So
Right. So we'll continue letting providers know that they, that it needs to be a reasonable time frame and a reasonable amount, and that they can contact Angie if there's some question. We appreciate that very much. And we understand that you are getting your marching orders from CMS at the same time. So, and this is, everybody's burned out. Everybody's caseload is higher than they want it to be. we have people out like the hospitals do, that are just not there, people that are typically in charge of some of these things, and with people out with COVID and related things, it's just a tough time. So we appreciate that.
It is. And the other thing I'd mention is if they're seeing an increasing number, it's probably because we had put them on hold, and so they're starting back up.
Okay.
And and the other thing is we start these things thinking, at one point we were thinking, oh well, are we seeing the end of this? And then a variant comes along, and here we are again.
Yeah.
And so again, I mean, if we continue to receive complaints about short timelines or MCOs aren't granting requests for extensions, that's a concern to us, and something we certainly would want to do something about.
Okay. Well, and again, we appreciate that. I mean, I think we're all in this together. We need to figure out how to make everybody happy with what's going on. But we appreciate your being supportive of the providers in this particular point in time. Thank you for that. The task forces ended in the interim final reports, and I think I sent you all the final reports and recommendations from the SMI task force, which was the one, of course, that we followed the most closely. So they had a dozen recommendations, number one of which, something that Steve Shannon and I have worked on for, I'm saying 20 years, Steve, that's probably an underestimate, to get a waiver for our folks with SMI that would provide supported housing and supported employment. There were a number of other excellent recommendations that would require funding besides the waiver. Kelly Gunning and her judge and Phil Gunning presented beautifully from Lexington about the mental health court. And we certainly heard, and the task force responded with a recommendation that there be more funding to get mental health courts out across the Commonwealth. They are a mechanism to get people into treatment rather than into incarceration. Now, we would like to move things upstream so that people don't get to the point where they are not compliant with their medication and their treatment and then commit a crime, which typically is a disturbing the peace or that kind of thing. But we want more mental health courts out there. They also recommended that there be more funding to get Tim's Law out across the Commonwealth. And we know that DBH, DID has the SAMHSA grant. They're in the second year of it. It's been slow going because of COVID, but they are working with Central State Hospital, Western State Hospital, and the community mental health centers associated with those two hospital regions. And we need to see Central Kentucky and Eastern Kentucky, Southeastern Kentucky also have access to Tim's Law. We also have some, there was a bill that was heard in committee today with some change in language that came from Judge Stephanie Burke in Jefferson County as a district court judge, who's probably been the biggest supporter, the most outspoken supporter of Tim's Law from the judiciary. And it cleans up some language in 202A where examination and evaluation are used in different ways in different parts of the statute, and where the timelines are not real clear. So it might say, such and such hearing has to be held in 6 days, but it doesn't say what the starting point is. So it could be any 6-day period. And then she had some very specific recommendations about some change in language on specifically on Tim's Law, removing the term anosognosia, which is the person's inability to realize that they are sick, and it's really a brain disorder. And removing that language and replacing it with somebody who has had at least 2 involuntary hospitalizations in a 48-month period, or 2 arrests for dangerous behavior on the basis of their illness. And she feels like it would open up Tim's Law, make it easier for people that really qualify and need those court-ordered outpatient services to get that treatment. So Ken Fleming had that bill, and it's House Bill 127. It was heard in Health and Family Services today and passed unanimously, so we're on the move with that. There also were recommendations that came out of the HCB 1915 C waiver task force for essentially significant increases in pay for those frontline workers, those personal service workers that provide those waiver services. And there is money in the House Bill 1, the House budget, to increase that. So that's kind of the status from the interim session task forces. And really want to thank those of you who are on this Zoom or whose agencies participated. We had excellent testimony to the SMI task force about the full range of services needed, and some excellent testimony by persons with lived experience and family members. And I always think that that's what gets the most attention from legislators. So we thank you all for that. As I've done in the past, I've got a bill grid that I finished up at about 11 o'clock today, so I'll send it out after we conclude this message, but I thought it would be helpful to you all to see some of the behavioral health bills that the Mental Health Coalition has been supporting. And some of these are about certainly supporting everything that came out of the SMI task force, both in the budget as well as in other policy changes. We're interested, obviously, in making sure that the CMHCs and the other quasi-governmental agencies are kept whole and meeting their pension obligations. We want to see the SMI waiver and other recommendations funded. There will be language coming from the school psychologists, school social workers, and school guidance counselors for more funding under the School Safety and Resiliency Act. That's the last passed as Senate Bill 8 in the 2020 session, to put double the amount of money in there to get more mental health providers into the schools. And then a really important piece that you all may not be all that aware of is the 988 line. So one of the bills that was passed during the Trump administration, in fact, I'm told by Marcy Timmerman, who's an expert on this, that it was the only bill that was passed unanimously during the Trump administration, establishes a 988 line, which would be parallel with our 911 line. So instead of having the National Suicide Prevention Line, which, as you know, is a 10-digit number that people have to remember, all they have to remember is 988. We have a real advantage here in Kentucky over some of the other states because we already have a statewide system through the CMHCs of answering those calls. And one of the important parts about making 988 both viable and useful is that they be answered close to where the person that's calling actually lives. We don't want this to be farmed out to somebody who's in, Alaska or Florida or a foreign country or anything else. We want it answered by those CMHC crisis line workers who know the resources, who could direct somebody to those resources locally. So we need to do a couple of things. The governor's putting some money in to launch the 988 line and to make sure, in fact, he's putting some additional money in. We were delighted to hear yesterday to fund 170 additional staff members for those call centers. So that's a huge piece. And then we need to keep it going. And so a number of us, Marcy Timmerman from Mental Health America, Megan Cole from the American Foundation for the Prevention of Suicide Kentucky chapter, and myself are working with a legislator to file a bill that would put a 70-cent a month fee on every mobile phone line. And that $8.40 would be enough to fund the line and keep it sustainable. So this is a national initiative. That line will be rolled out on July 17th of 2020 of this year. So we need to get these funding pieces in place. And it would be a suicide prevention and mental health crisis line. You are aware that in some jurisdictions, I'm thinking of Jeffersontown, which is a part outside of Louisville, they are using social workers. The city of Louisville is going to begin having social workers go out on calls with police. What they'd like to do is to be able, like they deploy the CIT teams, to differentiate calls that are coming into 911 and really should be 988 calls, where you don't need a police response, but you may need a crisis counselor or a mobile team to respond. So that's another piece of this. So I'll send this tracking document out to you. If there are mental health issues that you're tracking and would like to see it on there, I'm happy to add them. As we get bills filed, for instance, we've talked about there may be a bill on easing the EMS transportation problems from facility to facility. We may also see legislation on the 202A transportation. So we will add those bills for your consideration. I think you all have found that helpful in the past, just to as a way of kind of checking what's going on in the legislature. I guess I will ask, and I haven't seen anything, Charlie or Veronica, I haven't seen any updated prior auth guidance. Is that correct?
That is correct.
Okay.
Status quo.
Status quo. We like the status quo right now. So that's easy. So the status quo remains no prior authorizations on behavioral health services except on medications. Steve?
Sheila, what about the state of emergency? Is that due to end?
Yes. You want
Yes. So state of the public health emergency currently is scheduled to end on Saturday. We've not received confirmation of the extension, though it is expected. CMS did tell us that we'd be given a 60-day notice prior to the end of the PHE, and that has not happened. So that is why we're pretty optimistic that that is going to be extended. I don't know why they have us all sitting at the edge of our seat on this, but because we'd like to see it in writing. But yes, we're monitoring that.
I think, though, that the emergency orders that were issued originally by the various licensure boards to ease reciprocity, to allow licensed professionals to perhaps be able to practice without some of the licensure restrictions, those also are due to go away on Saturday.
That's
and
correct.
my emergency was that I had to take a call from a legislator because there are rumors flying all over Frankfurt about whether it's going to happen or not. And quite frankly, the last I heard was that it's not going to happen. So we shall see. This is a bad deal if that's what happens, because we've got people, there are a number, for instance, of nurses that have been able to come into Kentucky and provide services without having to jump through hoops in terms of licensure. I think there are psychologists and other mental health professionals that have been able to work across state lines much more easily than will be the case if these go away. So I'm really upset to hear that it may not happen. They are not going to meet tomorrow in session, so it either is going to happen today before midnight, or it's not going to happen. So I'm pessimistic, and I'm not.
I had heard Senate Bill 25 extended in committee sub.
Well, it did, and it passed the House State Government at noon today. But there are some pieces that were taken out of some of those executive orders. And even though that also has the NTI days in it, those traditional instruction days, which every school superintendent, every parent is waiting to see how many of those NTI days may be happening. The last word that I heard was that even if the House passed it, that the Senate was not going to pass it for unknown reasons. So,
Sheila, excuse me, just to add some importance to staffing and allowing that flexibility. We just learned that the Supreme Court upheld the CMS vaccine mandate for CMS funded facilities, which now means that folks who are in our facilities who are unvaccinated will no longer be able to stay employed. So we're really very concerned. Obviously, we fully support vaccines. We believe it is the answer. We believe folks should get vaccinated. But we have only 64% vaccination rates at some of our facilities. If we lose 40% of our staff, we'll be unable to operate some of our facilities at current capacity. So this out-of-state flexibility is really just became very much more important.
And I'm afraid that we're going to lose it today, Alan. So that was the ruling from the Supreme Court.
Correct.
Wow.
They upheld the OSHA. I mean, they, I guess, ruled against OSHA requirement. But yeah, the CMS one, I guess, is a problem.
Yeah, it's not the employer mandate. It's the CMS funded federal facility. So it's nursing homes, psychiatric hospitals, ICFs,
anybody that gets CMS funding, right?
Correct.
Gets Medicaid.
Certified CMS providers.
Certified, okay. Oh, well, how much other bad news? Thank you, Alan. I know you didn't want to report that, but wow.
I told you, Sheila, not to say your day couldn't get worse.
Well, I just said that. See, I really jinxed us. Bart told me, he was over there going, no, don't say that. Do we have any recommendations for the MAC? Yeah.
Yeah, just real quick on that last subject that Dr. Brenzel was talking about, because that's just kind of coming out. I was just kind of seeing that too. Upholding the CMS requirement. We seem like we discussed at a recent CMHC CEO meeting that CMHCs did not fall under that because they didn't meet the federal definition. Has anything changed on that? Does that?
I think there may be one that does, but I'll have to recall because they have facilities. I'm not sure if River Valley, if they operate hospitals or certain levels of a program. So we'll have to double check on exactly.
That would be the only one.
For sure.
Okay.
Yeah.
But the
it's certified facilities, and even if you get Medicare and Medicaid funding, you're not necessarily a certified facility, and that's the distinction. But yeah, I would think that would be a concern for River Valley.
Yeah.
Unless our hospital is independent somehow, organizationally.
Right. But
So
the state hospitals and a PRTF and
nursing homes,
Nursing
right,
homes.
Alan?
Nursing homes, sure. But I don't think our CMHCs operate nursing homes at this point.
No.
Yeah, I know, but I'm
Yeah,
thinking
it definitely applies to nursing homes primarily. That's what it was targeted at primarily.
Right. Wow.
And a PRTF, as far as you know.
Well, that's a really good.
I don't know if they're Medicare certified. That's the piece.
Okay. I mean, they're federally defined, but I don't know that they're.
Yeah. And, the CMHC is in federal definition, but the certification part, if they operate partial hospitalization programs, which, and certified to do that specifically, they may have them for kids or such, but it's not that process is why it doesn't apply. except for maybe River Valley with the hospital.
Right.
Right, Dr. Renzel?
Yes.
All right.
But it's definitely going to be your hospitals and your nursing homes.
Correct.
Yeah.
And
Western
ICS.
State, Central State, Eastern State,
ICFs,
right?
yeah.
Yeah, and ICFs.
Wow. So if I'm right, the Senate Bill 25 is not going to go, then you don't have any of the flexibility for bringing people in from other states. And if you have any APRNs that have been operating without what we call a Kappa CS, that was suspended, see, that's going to go away too.
Call them, yeah. We need to make sure people are aware of that additional complication.
Well, and it's gonna happen on a Saturday of a vacation, a holiday weekend during one of the biggest spikes of COVID that we've seen.
Yeah.
I guess the biggest in the state.
All right.
We
Makes
have
no
for sure the highest numbers of COVID. We have facilities with 40% of the patients are positive now. So.
Wow. Wow.
Sheila, is there any way there could be an emergency regulation because of the reasons that you guys just said?
Well, that's what these EOs, these emergency orders, were written to do.
I know, but I mean, can another one be issued or no?
There's nobody to issue it.
Got it.
I guess would be the problem.
I was just hoping to get.
Well, and in the special session back in September, there was a lot of discussion about these executive orders, and that's when they set this January 15th. It's a completely arbitrary date. It has nothing to do with the national, CMS designated executive or emergency period or anything else, but they tied their own hands. And it's just really mind-boggling that they're going to do this.
And prevent the governor from extending it, right?
There's not going to be anything that the governor can do because they've taken away his emergency power.
That was my question.
Yeah. Yeah, I don't think there's any way out of it. So all the school principals and superintendents and parents that have been waiting to see about NTI days, and then everything in healthcare, mental health and physical health, is just absolutely up in the air. And down the tubes, probably, with this.
Till Tuesday.
Till Tuesday, yeah.
Maybe. And
well, and then how do you get people back in? We've had this thing once before where we say, if you on an emergency basis close down a unit or whatever, you can't just flip a switch and turn it back on. Lots of things happen when you turn it off. And so if you've got people that have been working here and no longer can, what do you say to those patients? I mean, we really have to think about patient care here. Wow. I don't have any agenda items for the March meeting. Do any of the other voting members of the TAC have any agenda items, or I'm sorry, recommendations to the MAC? Maybe we should recommend to the MAC, well, I mean, the emergency orders need to be reinstituted. But, that's outside, that's not something that Medicaid has any power.
No, I think what you should recommend is everybody call their legislator.
Yeah.
Yeah.
Yeah. Well, we're going to end this meeting pretty soon. You can go call your legislator now and say, what are you thinking? So we've got lots of carryover items for the March BH-TAC meeting, and we will carry those over. And if anybody that's on the call wants to email me at kyadvocacy@gmail.com, and you get emails from me, let me know what other items you want to add. And then the MAC meeting is the 27th of January, 10 a.m. to 12:30, and that's via Zoom. And then our next BH-TAC meeting is March 10th. Remember, we've gone to the second Thursday of the month. And that will again be at 2 o'clock so that we can let the legislative committee meetings happen
Guess everybody's heard about our recent losses. We lost Larry Forgy and then our
Yes.
dear advocate friend Bernie Block.
Bernie Block, yeah. I went to that visitation. It was at the same funeral home and so forth where his son David had his visitation after he had successfully completed suicide. So sad. Bernie was a great warrior, great guy, and willing to talk about his son's travails and try to do something about it. So he's sorely missed. But his family was glad. There were a number of the old timers, Kelly, the old time NAMI Louisville people were there, and it was good to see them. They're very excited about the prospect that we could get an SMI waiver this session. When I told them that that was a possibility, they were all just so excited about that. So it made me feel good that, they were there to honor Bernie. But you're right. And those of you who know Senator Alice Forgy Kerr, of course, that's her brother, her beloved brother. And I'm sure that she is deep in grief. So prayers for both of those families. And if there's no further business, we will adjourn the meeting, excuse me, by acclamation. And I thank you all for being on. Welcome again, TJ. And we will see you all in 2 months. Thank you very much.
Thank you all.
All right. Bye-bye.